Hello, all. Good evening. Welcome. Good evening, Dr. Anand.
Good evening, Dr. Abhishek.
Good to see so many people joining in so early once again. Good evening, Hafiz. Good evening, Dr. Dinesh. Good evening, Dr. Virender. Today we are into the last session, last class of Endo Master Class Season 1. Definitely, we are going to have more classes and more sessions in the future. But this one is the most important session. We have Dr. Vinay sir with us tonight live, and please welcome Dr. Vinay on the screen. Dr. Anand, over to you.
Good evening, sir. How are you?
Fine, thank you very much. Anand, how are you? Thank you very much, Abhishek.
Good evening, sir.
Good evening, very good evening.
Thanks a lot, sir, for joining us. Just as you mentioned, a very brief introduction about you. I'll be very fast and very brief, and then the stage is all yours, sir. So, Dr. Vinay Shivagange, sir, he is from Bangalore, Karnataka. He completed his graduation from the University of Mysore and did his post-graduation in conservative dentistry and endodontics in 2008, securing the 9th rank in the university. His main interest, as the topic for today, is microscope-based endodontics, right from the post-graduation times, and has won multiple paper presentation awards for the same. Since 2008, Sir has been practicing microscope-based endodontics in Bangalore. Sir is on the panel, the KOL for Dentsply, FKG, Zeiss, and Media companies. Since 2014, Sir has moved to the Sultanate of Oman and has been a course leader in endodontology in the Oman Dental College, Muscat. He is the only second expat to have specialist license from MOH and has exclusive private practice, which is microscope-based endodontics in Oman. He was awarded as the best faculty of ODC for the first time ever in 2017. Sir is also the adjunct professor at the prestigious Savita Dental College, Chennai. I guess, sir, I was pretty fast.
Thank you very much for the short and rapid introduction. Thank you, because I didn't want you to waste much of my time and people who are joining here, so that we can go ahead with our presentations,
The stage is all yours. Abhishek will put up your presentation and we can start, sir.
Okay. If Abhishek gives me a go, then I am ready.
Yes, please start, sir. Please start. All set.
Okay. Is my first slide visible?
Yes, sir.
Yes, sir.
Okay. Thank you very much. A very good evening, everyone, dear colleagues, friends, teachers from whichever part of the world that you have joined here. As you all know, today is September 5th, and in India, we celebrate this as Teachers' Day. So on this day, I had requested Abhishek, actually, he was asking me what date would you like to give, because here we have a holiday on Friday and Saturday. I told Saturday should be very good, and also it is a very auspicious day for us on the Teachers' Day. So this presentation of mine is a tribute to all the teachers that have taught me over the period of years, and probably our prayer, as we all say, which is there on the screen, tells us that the teacher is the ultimate God who actually molds us to what we are today. So I would like to offer my humble gratitude, and I bow to my boss, Dr. Manjunath. He has been a driving force for me during my undergrad and also postgrad, and after post-graduation also, over a period of time, that even today he guides me in so many things. I thank him very much. Dr. P.D. Joshi, he has been my mentor in the microscope-based endodontic journey. And Dr. Glenn Van, he's a very good friend who has inculcated a lot of good things about microdentistry in me, and many more teachers. And I would like to add a special note to here about my guide, postgraduate guide, Dr. Vasundhara Shivana. She had been a driving force behind me when I was working on the microscopes in the postgraduate life. She supported me all through, and has been one of the major forces for me to be today working on only microscopes. So the second part is, I would like to thank the World Dental Association, for having brought these kind of teaching modules so that we can reach more number of people. Uh, Thank you very much, Dr. Abhishek and the entire team for working on this. And I thank them for giving me an opportunity to share my experiences. This is what I'm going to tell. I'm just sharing my experiences, my journey in the field of microscope based dentistry. There are a lot of hardships that we have gone through. Today it looks more easy, so I would just like to share a few experiences, and then I'll be very happy to take some questions probably at the end, so that I can share my knowledge, help a few who are interested in further taking magnification into their daily practice. So as we know, the topic for today is magnified dentistry. I did not limit myself to magnified endodontics, because as we discussed with the team, a lot of people like the general practitioners would be there, a few postgraduate students, a lot of dentists who are already practicing. So I thought, let me modify my presentation as magnified dentistry. And the tagline here is through the lens that augments the size of certainty. That means the lens is the tool that I'm going to use for having the magnification, and size does matter, because what we see is what we are going to treat. And if certainty is a word that has a high value, precision dentistry, that is what we all need to look into. Yeah. So as I go through the process of this presentation, you would be able to gain a few things. And this is the first video that I would like you to see, my courtesy to Dr. Marco. This is a mandibular first molar, and this is a micro CT. You can follow Dr. Marco on the blog root canal anatomy blogspot.com. Please observe the hard work of Dr. Marco, where he is giving us the micro CT of the pulp tissue. Just see the anastomosis, the canal, and everything. Now coming to the second video, it is the mandibular first premolar. Why I chose this is for one reason. The mandibular premolars are considered as the enigmas of endodontics, and this is one tooth which gives all the vertices classifications in their anatomy. So if you can see, there is a lingual canal, the buccal canal, it goes and splits into two in the middle third. So if people are interested, they can go to root canal anatomy blogspot.com and see a lot of videos, lot of teeth, and it is going to help you to understand how the anatomy is. This is technology. Now coming to this slide, please see the year. It was in 1925. This is a histological section where Dr. Hess, he decoronated the tooth and he injected dyes into the radicular area. If you see here, you can see that there is a mesobuccal tube, MB1, the palatal. I'm talking about the right side picture, which is of the maxillary. You can see both the canals, the MB1, MB2, the palatal, and the distobuccal. See the anastomosis. And then if you consider the image on your left hand side of the screen, probably for me, it's the mandibular molar. You can see the lateral canals. You can see the isthmus area. So this was way back in the year 1925. Just imagine 1925, and today we are in 2020. It's about 95 years. This was the idea what Dr. Hess told us. The anatomy is like this. Now that is what I am requesting you to go back to Dr. Marco's website and look into the recent things. Now, why I put those two slides is to correlate these taglines. You don't know what you don't know. If you cannot see it, you cannot treat it. This is what is very important. And you don't know what you're missing. As simple as that. So these lines are very important in the field of magnification, because if you're not able to see an MB2, obviously you'll not be able to treat it. And the patient is going to come back after, say, 6 months. Doctor, whenever I bite something hard, I still feel some sensitivity or some tingling sensation. And you'll see a radiograph, and if you are not able to identify an MB2, you would say, my obturation looks fine, so please take care not to eat anything which is very hard. That's not what we are supposed to say to the patients, right? So you don't know what you're missing there. This is what is the bottom line. Now, we as endodontists and the dentists, over a period of time have always told that whatever we do is all blindfolded. We work with the light which is coming from the chair, and the penetration of this light is not as good as what we get with the help of the right tools. Like if you have a microscope, the coaxial illumination is fantastic. And if you are having an LED light over the loop, that gives you a fantastic depth of penetration of this light. So we used to say there is nothing to see. We always used to tell, okay, I'm feeling the apex, I'm feeling the curvature and other things. But with the right tools, we have a lot to see. A simple example is a matrix band adapted to the walls perfectly. This is what you need to see. If not, there is some leakage coming from the proximal area, the blood is seeping through, and when you do a restoration, the occlusal surface looks fine, but there might have been a thin layer of saliva or the gingival clavicular fluid or the blood which has seeped under the flowable composite or whatever you place, and the bonding efficacy has lost. So this might lead to a failure over a period of time. So that is what we need to look into. Now, operating microscopes, what are these? These have been used for decades, in the other fields of medicines, such as ophthalmology, reconstructive surgery, vascular surgery, everywhere. But it took time for the same microscopes to come into the dental field. So we have to really be happy today that magnification has already come into the dentistry. But if you go back to about 20 years, 30 years back, it was something out of the blues. Now, what I would like you to understand is everything has changed in dentistry. Yeah, you saw the two figures, except the anatomy. So in 1925, the anatomy was the same. In 2020, also, the anatomy has not changed. But the question is, have we changed? Should we change? We are still practicing the old way. Some of us, probably. Even I was doing the same thing before I bought my microscope to my practice. I was also doing the same old kind of dentistry. I will tell you what are the advantages, disadvantages. And today, there is a call for the change. You need to get in touch with the technology so that we travel in time for more amount of period doing quality dentistry. That is what is very, very important. So a brief about the history of microscopes, because basic topic is magnification. So to understand that, I'm taking a few slides. So the history of microscope, it is Zacharias Janssen in the year 1590. He was the original inventor of the microscope. And then in 1609, Galileo, he came up with his version of the microscope, which he termed as oculino. And then Robert Hooks and Galileo, they are very famous. And in the year 1665, he designed a microscope, which he explained in his literature as micrographia. If you can see the bottom picture here on your screen, you can see how primitive that microscope was. 450 years back, they had this idea of microscope or probably magnification. We really need to appreciate them. When in 1977, Dr. Robert Baumann, he was an otolaryngologist, and then he suggested, why not people use microscopes in dentistry? So it was an otologic microscope. It was not the regular dental operating microscope, what we have today. Following that, in the year 1978, Dr. Apotheker and Jacko, they designed the first dental operating microscope, or also called as the Dentiscope. This is the picture that you would be able to see on the screen. It had a lot of problems, basically. It had a fixed magnification. It was about 8x, and the arm movements were very difficult. There was no light which is helping the dentist to see through the microscope. There's no documentation, and it was very difficult to use. But at least the concept came into being. So it did not get well accepted by the then dentist, and it slowly faded away till 1993. Or before that, Howard Selden, he was the first endodontist to publish an article in the use of operating microscopes in endodontics. But he was mentioning more about in general part of the endodontics, not in the surgical part. In 1993, there was a first symposium on microscope endodontic surgery, which was held at the University of Penn. And following that, in the year 1998, the American Association of Endodontics, they told that microscope should be a part of the teaching in the postgraduate level. So all these dentists who endodontists who graduated post 1998, they had been at least aware of how to use the dental operating microscope from the beginning in their academics. Now, in 1999, Dr. Gary Carr, you really need to appreciate his efforts. He introduced the dental operating microscope that had Galilean optics. I will, in a following slides, I will tell you what it is. This dental operating microscope had a magnification changer. The previous one had only 8x, but this microscope had 5 discrete magnifications, and it also had an assistoscope, so that your assistant who is watching what you are doing, she can be of much help if you can observe the picture. And there was a coaxial illumination, and the arms were well balanced, and the microscope was very sturdily standing, and there were no fine movements. So that is what was Dr. Gary Carr's microscope was. Now, the efficient use of magnification in dentistry, as we all know, it slightly requires an advanced training because it is not taught in the dental schools on a regular basis. But I know a few of the colleges now in India, they have introduced the use of magnification, at least to the level of loops. And in Savita, as I know, we have introduced the use of loops from the year 2 in the preclinical labs. So they start to get the new skills from that time itself, and they are using the same during their first 2-3 years before they graduate. And it is the only college which has about 16 microscopes, and all the postgraduate teaching happens under the microscope. This is a fantastic thing. So I was so happy when I visited Savita way back in 2014. I saw 8 microscopes. I was like, wow, that's something really good which is going on in the teaching. Now, I would like to go to a few points about optics. Why? Because you need to understand magnification. What is magnification? What I need to know before I buy a microscope or before I buy a loop, and why I need to buy these things. Now, coming to the a terminology called as resolution. It is the ability of any optical system, such as our eyes, such as a camera lens, or even a microscope, to make clear and distinguishable two separate entities. The resolving power of an unaided human eye, that means the eye does not have even the prescription glasses, or it doesn't have a loop, is only about 0.2 millimeters. What does it mean? Say if there are 2 lines and they are separated by about 0.1 millimeter apart, our eyes will feel that it is only one line. So that is what is very important. The resolution of a normal human being, the normal eye, is about 0.2 millimeters. Why is this very important in dentistry? Clinically, most of the dental practitioners will not be able to see an open margin which is smaller than 0.2 millimeters. What does it correlate to? Say you're doing a composite restoration, and there's an open margin between the tooth structure and the composite, which is about 0.1 millimeter or 0.015. We will not be able to see them. and that is good enough for the bacterial micro leakage to happen, and over a period of time that restoration is going to fail. Consider the same thing in an endodontic procedure. Consider the same difference when you are seating a crown. If there is a marginal adaptation which is less than 0 point, we will not be able to observe. So all these things might over a period of time lead to failure. So to understand the basics of magnification, I'm going to give two examples of our day-to-day scenarios, what we see. This is the currency note that we used to have. So I am still holding back those photos as a part of the teaching process. Mahatma Gandhi is there on the currency note. Everybody has seen this. My request is observe the eye. Yeah, it looks like a blot of ink. That means it's a black dot, and in the center there is no ink, which shows the pupil. This is already a magnified image with the microscope, which since I had used the microscope, it's at about 3x, 3.1. I'm rounding off to the number. Now, what I would like you to observe is the pupil there. This is at about 5x magnification. Okay, I will go to the next one. Again, you see the magnification on your lower bottom screen. This is at about 8x. Yeah, just I want you to observe only the pupil part, nothing else. And now this is at about 13x. Now you are able to see some concentric lines there. So that blot of ink is actually not a blot, but they are concentric lines, which probably are less than 0.1 millimeter apart. So that is why our naked eyes will not be able to see. Very simple. If you have your currency notes there, you can just take and you can just see them. You'll not be able to see the concentric lines. And the next slide, which is going to show at about 20x magnification. This is what is the highest magnification in a microscope, 21.25. Okay, so here you are able to see those concentric lines, and you can see the striations also. So what is the difference? Just see this image. You can see the two images. Now, this is something that we see regularly. This is the moon, and I'm going to run the moon, and I'm going to magnify with the camera and see how it was. And now when we go closer, we are able to see the craters there. Yeah. Now we will zoom back. So this is the highest magnification that you will be able to see with your high-end cameras of Nikon, any of the digital SLRs. And then you zoom back. Now you will know what is the difference between a magnified image and the naked image, what we see through our eyes. This is what we usually see. So now you will understand, okay, there is a part of magnification in our daily life. Now you can only treat what you can see. That's what I said at the beginning. So you can see more, then you can treat more. This is one of the images of a broken instrument inside the canal. So this is how I'm relating things. So what we saw is in our daily life. This is what we see in our dental life. Yeah, I will come back to this picture at the end again when we go back to the clinical scenarios, why magnification is required in dentistry. Now, as I said, we are all restorative dentists, periodontists, endodontists. Everybody can use some kind of a magnification. It is not only for endodontists. Anybody, any general practitioner or a specialist can use any kind of magnification, because whatever procedures that we are doing regularly in dentistry, they require a resolution well beyond the 0.2 millimeter limit of the human side. I know a few of the dentists also use a microscope to place implants. They also do extractions under the magnification. Good. Why? Because we are doing less traumatic extractions when we are using a microscope. And when we are using magnification for placement of implants, obviously your precision is going to improve. So any device that enhances or improves a clinician's resolving power is beneficial in producing precision dentistry. This is what is that we need to understand. So where are we moving from? We are moving from the regular dentistry to precision dentistry. Probably you would love to get a root canal done under a microscope if you know the benefits of that. Yeah, so that is how precision dentistry is. Now coming to the small table, what I would like you to look at, just see the first one. The unaided vision is about 0.2 millimeters, the resolution of the eye. But when you wear a 4x loop, okay, it becomes about 0.5 millimeters. So you will be able to see the difference. And then 4x is the limit of the loops, because if the magnification becomes anything more than 5, 6, they become more heavy. So usually we do not suggest a loop which is giving a 6x and other things. Now, if it is an 8x, it would be with a microscope. So you see about 0.25. And when the magnification is about 20x, yeah, so the resoluting power is 0.01 millimeter. This is very, very important. So from 0.2 millimeters, we are going 1 decimal less. That means 0.01 millimeter. This is the power of magnification. Now, doctor, why do I require a magnifying device? Without a magnifying device, we can increase the resoluting ability for our eyes. How do we do that? Two ways. Okay, simple thing. Either we go closer to the patient, we bend over, we go closer. That is what we usually do. If we are not able to see properly, we bend over. Second thing, we raise the chair so that we are sitting straight and the patient is going to come close by. Both are very detrimental over a period of time. Why? Because by raising the chair, we are going to bend either of them. So we'll have muscular problems. If you see the picture, a study in ergonomics has told that on the left hand side, I'm talking about a right hand practitioner, the left hand side, the muscles are stretched and the lung capacity is more on the left hand side, while because of the bending regularly to work on a patient, the right side is compressed and the lung capacity decreases over a period of time. So this is what has been proved, and which is not very good for us in the long run. Yeah, and most of the dentists will not be able to focus. You can also try right now, focus at a distance closer than 12, about 10 to 12 centimeters. So till here it is clear for me, but when I take it close by, I am not able to see my hand very clearly. Yeah, you can try that. So the eyes get strained if you keep doing that. In a similar way, we cannot go closer to the patient, come back closer to the patient, because our eyes, to get that resolving power, they start to constrict. And over a period of time, the eyes become strained and it leads to presbyopia. Okay, so that is also one of the disadvantages. Now this picture culminates everything about the ergonomics. I'm not going to talk much about the ergonomics. You can see here the naked eyes. This is how I used to sit. I'm not denying that part. When I was a student, when I did my initial private practice, this is how we used to sit. And then if we have reading glasses, we sit a little more farther off because there's no need for us to go close to the patient. With about 2.5x loop, we go further away from the patient because the working lens increases to about 10 to 12 inches. Okay, and then with 4.8x loop with the headlight, see the position. This is Dr. Glenn. Okay, so one of very good friends. You can see the fourth picture where he's sitting a bit more straight, but with the microscope, your ergonomic position is you're just sitting straight, you're perfectly fine, and you can go ahead working and you're far off from the patient. Okay, let me just give you an example of how it works during this COVID-19 pandemic season. You're far off from the aerosol generating procedures, and the amount of aerosol which is trying to reach you is actually very less compared to when you're working with your naked eyes or with whatever is the protection that you're taking. So another advantage why you need to move towards magnification. Okay. Now, coming to the different types of magnification devices in dentistry that we have been using. The first one is obviously most of you know, it is a loop. Second one, again, it's a microscope. Third one, sometimes people have used endoscopes. It is just like you're having a camera and you're running the camera in front of the patient's mouth, but you're seeing a device, a television or something, which is relaying this image. So you're not seeing it directly. Okay, this is mostly used by the gastroenterologist when they insert the camera and the endoscopes. The most popular type of magnification devices are the loops and the microscopes. Okay, I will go through, I will not cover anything about the endoscopes, but I'll cover a few slides about the loops. Why were these developed, the loops? A dentist, it did not develop because of dentistry. It is there already in the medical field, and we use the loops from them. Now, magnifying loops were developed to address the problem of proximity. As I said, to observe something, we used to closer. So to address that problem of proximity, they developed the loops. And then the decreased depth of field. Please understand this term. Depth of field is important. The first one was resolution. Second one is the depth of field, since I'm talking about optics. And the eye strain. Now, what is depth of field? I have two pictures. In the next two slides, you will be able to understand that to a better level. I have tried my level best to make you people understand. The depth of field is the ability of a lens system to focus on objects that are near or far without having to change the loop position or the lens position, whatever it is. So as the magnification increases, the depth of field decreases. So I have two pictures here. Now you can see this. The first picture on the left hand side on the screen is a walking path in the forest. This is having a deep or a large depth of field. That means the first tree and the last tree, you are able to see all of them, but the sharpness actually decreases from the first tree to the last tree, but you are able to see at least. While you come to the image on your right hand side, it is the shallow depth of field where you are able to see only one flower, very nice crisp image, while the other background is already blurred. So that is the depth of field. Now I have another picture, probably, yes, as I said, the magnification, as the magnification increases, the depth of field decreases. Here you see a camera which is kept on the grass, and you can see the background. Say, let us assume that it is about 3x. We come to the middle image, which is about 8x. The peripheral areas become blurred. So the depth of field is again reduced. And now when you come to the third image, you can actually read the name of the camera, Yashica, right? But you're not able to see anything else. Compared to the first image on your left hand side and this image, the peripheral area is completely blurred off. So as the magnification increases, the depth of field decreases. This is what is very, very important. Now, what is the problem in the regular dental field when people are working over a period of time? I know a lot of dentists complain of back and shoulder pain. They have undergone carpal tunnel symptoms, musculoskeletal pain, which a lot of dentists undergo. And then in one of the studies, it says that 29.5% of them, they go in for an early retirement. Okay, you see, it's a time for retirement. Yeah. Why? Because it is one of the, what do you say, these problems were not addressed at the beginning, and they culminated in an early retirement. So to address these issues, ergonomics is very, very important, and magnification is a part of the ergonomics when you're working in the dental field. Now, I'll go in detail a few 3-4 slides about the loops. There are different kinds of loops which are available. So you need to know what kind of loop should I buy. Why is that loop better than this? Okay, these are all much of the theory. I will just rush through them. you have three kinds of loops, the diopter or the flat plane. It is a single lens loop. Okay, these are something which I can relate to our school day times when we used to have those lenses, single lenses. So we used to take the lens and we used to read. That's a simple loop. When you have a single lens which is kept inside, that is a single lens loop. Now, as the technology increased, the surgical telescopes with a Galilean system was introduced. That means two lens systems. So you get a very good magnification of 2x up to 4x. And then you have a surgical telescope with a Keplerian system configuration. That is all theoretical part. But for you to understand what it is a prism roof design. The previous one had lenses. Now this has a prisms. Okay. Now I'll show you the picture after 2 or 3 slides. You will know the difference. The loops produce a working distance of about 11 to 20 inches. But the more ideal to work with the loops is about 11 to 15 inches. So you'll be farther off from the object where you're working by about 11 to 12 inches or 15 inches. So that is a suggested working distance. So when you're buying a loop, you need to know what is a working distance. And it also depends upon your height, basically. For short people, it is a shorter working distance. For tall people, the working distance will be obviously longer. Now, the Galilean system, it gives a magnification from 2x to about 4.5x, while the prism loops can give up to 6x. But as we go to a higher magnification, as I already said, the loops become more heavy. So there will be a strain on the neck muscles when you wear these loops, because you need to keep balancing the loops. So you have to be aware before you buy what is the weight of the loop. Say, just don't go to anybody and just buy a loop. Tell them, I need it for 1 or 2 days because I need to use it. I need to know what is the weight of that, so that am I comfortable or not. So do not buy a loop right without using a demo unit. Please, my request is that. Now, as I said, you need to understand what is the working distance. This is a small picture that you need to understand. If you can see the magnification at the bottom, it is fixed, at about 2.5x. Now, what is the field of view? Now, the working distance, as I said, it runs between 12 inches to 22 inches in this. So what happens at 12 inches? See the line number 1, the first line. The working distance is 300 and the field of view is only 67 millimeters. So a working distance of 12, the field of view is small. When the working distance increases, when I go farther off, the field of view increases. So usually what we suggest is to buy a loop between 350 to 400 millimeters. That is a working distance, which is about 14 to 16 inches. Okay. And if you're tall, more than 6 feet, then you need to look at using a 450 or a 550. Okay. You get a 500 also. So you need to look at that. So before you buy, please request the representative to give a demo and feel comfortable. What are the different working distances that you are comfortable with? Okay. Now, these are the 2 loops that I was mentioning. One is the Galilean system, which has only the lens, while the Keplerian system has prisms inside. So obviously, if you see, the right side is slightly heavier than the left side. Okay. Now, what are the disadvantages? Everybody always talks about advantages I want to sell, because they want to sell it to you. Now you need to know why I need to buy a loop. What are the disadvantages? The disadvantages, first one, it works on a convergent lens system. That means if you see this person, he is reading, wearing the loop, and it is pointing at only one place, right? If he has to see the last page or the top part, then again he has to move his head or up and down. So that means the adjusting or the focus is made by the neck for the slightest movements. You cannot move further more than 2 to 3 inches, because the field of view completely changes. Now it is having a fixed magnification. 2.5 is always fixed. You cannot change it, vary it suddenly. Okay. Now there's no integral light. You have to have a light on the hood of the loop. So again, that also adds to the weight of the loop. So you need to discuss with the representative what is the weight, how it is helpful to buy what loop with what light. Nowadays, most of the companies, they are coming up with LED lights which are of less weightage. So it is a very good scenario now. Now you cannot document. This is one of the disadvantages. There is no documentation. You cannot attach any camera. I know a few people who attach a GoPro and they try to work, but that's all. You cannot work regularly with those things. Yeah. Now the second part of the this thing is magnification. 8:14, about 40 minutes. Okay. Dental microscopes. Now these are designed on the Galilean principles, which is called as a telescopic system. Okay. And the focus is at infinity. Previously, what it was a convergent, but this is at infinity. The microscope sends parallel beams of light to each eye back, and then it allows for a three-dimensional viewing with an excellent depth of impression of depth. Okay, you need to just understand this. I will show in one of the pictures what it means. So when you want to buy a microscope, you need to understand what is the optics quality. This is very, very important. My question to anybody who asks, doctor, can you please suggest a microscope? I will, first question would be, how expensive is your eyes? You know, because if you buy a loop which does not have a good quality optics, or if there is a distortion of the image, any of the problems, what is going to get affected? The first thing that will get affected is your eyes. So whatever is the worth of your eyes, that is the investment that you need to make. Yeah. So I hope you understand what I'm trying to tell you, people. Money is not the only criteria. You need to know what you're going to get back from that. Yeah. So optics quality, we have an apochromatic lens which is not having any light distortion, and you cannot have rainbow colors in that. You need to know, and the image what you're seeing, the light should be able to pass through or reflect completely. A lot of things that you need to know. Optics quality is the primary step that you need to take. So you need to look at some good brands of companies of microscopes or the loops. Then coming to the microscope stability, as I said, you have an arm, you have a floor mount, or you have a ceiling mount or a wall mount. The microscope should be stable. When you pull, it should be able to be maneuvered with the help of only 3 fingers. You just take and put it. It should not be dancing. Like the arm should be stable. So when you sit and watch and when you're working, the microscope should not be moving there, because when the microscope is moving, the image is not clear on your eyes. So it has to be very, very stable. So you have to be taking into one of the consideration. Maneuverability. Say in India we have a dental office which will have about 4 or 5 chairs or 2 chairs probably. Okay. Now if I am working in a section 1 and I want to go to section 2 tomorrow because this chair is not working, I should be able to move the microscope initially. But if you're sure that I can afford to get 2, so maneuverability is something that you need to decide before you buy the microscope, whether you want a ceiling mount or a wall mount or a floor mount, which you can move it across the operatories. Okay. Coming to the modularity, this is something very important. Say you buy a car and I want to get some accessories done, whether it's from outside or from the same company, it should be able to accept these changes. In a similar way, if I buy a microscope today, I want to add some accessories tomorrow. So it should allow me to add the accessories which might come in the future. Buying a microscope with an integrated camera is one of the disadvantages that personally I feel. Why? Because when I go through the videos, I'll show you the image what we used to get previously, say 10 years back, was of poor quality. Today we have a 4K. Probably in period of time we might already have an 8K, 16K. So if you're not able to upgrade the cameras and it is already integrated, that's a disadvantage. So you should be able to upgrade your microscopes without much of the expenses. That is modularity. Okay. Now, as I said, the illumination system, if you can see the image, the red arrow at the bottom is the light source which is coming, and it reflects back from the mirror. It goes back into the microscope. And then it is a convergent line, right? It's about converging for about 2 to 6 degrees. Then it passes through multiple phases of the lenses. It gets reflected, and by the time it comes out through the eyepiece, it is a parallel image. It's a parallel beam. So you are able to get an image which has a very good depth of view. Okay. Now there are different kinds of lights. As I said, you can have a halogen light. Now more acceptable is the LED lights. You also have a xenon light, which is very expensive. Now coming to the parts of the dental operating microscope, you need to be aware of that. Just give me a second, please. There is something which makes the dental operating microscope unique from the other microscope. It is the tiltable binoculars. Yeah, this is what is very important. If you go to any ENT, they have a fixed binocular of 45 degrees. Okay. So I have seen a lot of dentists also using a fixed binocular system because it will be fixed. You cannot move. But with the tiltable binoculars, you can move the binoculars. You can see the top image from 90 to 180 degrees. So it can go full length by about 90 degrees. Now there are different parts of the microscope. The left side microscope is what I use. It's an Zeiss OPMI Pico. And on the right side, you have a Pro Ergo, which is a completely motorized one. So you have various microscopes in the market, but make sure that you look into the optics quality, you look into the maneuverability, what I said, and the modularity before you buy. Nowadays, there are a lot of microscopes which are coming up with fluorescent lights, yeah, or the filters to diagnose caries. So a lot of new things are coming up. So we need to have a microscope which can be upgraded. Yeah. Now these are the imaging modules. You can connect either your digital SLR cameras or my preference is to have a handycam, which is of a 4K quality presently. Previously, I had a regular HD, and before that, I had about 480 pixels or something. I'm not sure about the old one. So these are all the imaging modules. These are the ones what I told as the accessories. Now, this specific slide is for the postgrads, which I felt that a few of them would be there, as to calculate what is the magnification what we get from a microscope. If you see, there is a formula, M total, that is a magnification total, is equal to F, that is the of the tube, the focal length of the tube, and the focal length of the objective lens. Everything will be etched on the microscope. So you just have to take those numbers, and G is the magnification changer, the factor of the magnification changer, and M is the magnification of the eyepiece. So you just need to calculate and you will get the magnification. This is the formula that you need to use, because a lot of microscopes come with a 10x eyepiece. So there are different numbers. To calculate what is the number, you need to use this formula. I have just calculated for a 10x magnification and a 12.5x. So the magnification goes from 2.72 up to 21.25. So these are various combinations of the magnifications that you get from the microscopes. Now, this is the comparative aspect. I have already told what are the features of the loops, but with the microscopes, it's a wide range of magnification. It changes from 2.7 to up to 21.5, and there is an integrated light. It's a shadowless light. Documentation can be done with the help of an integrated camera or any other cameras. And the focusing is done with the microscope. The microscope can be moved up and down instead of moving the head up and down, right? And then you have the micro instruments. These are the instruments which you need to buy over a period of time for using. Now I will tell the disadvantages of the microscope. Dr. Vinay is not only promoting the advantages. Yes, there are certain disadvantages of the microscope. The learning curve, it's about 6 to 9 months to become proficient in one single procedure. I'll show you one graph. The workplace arrangement and the seating posture changes. Okay, the skill acquisitions. Say you already have a workplace and you need to rearrange certain things for getting the microscope in place. Skill acquisition, it takes time. My way of telling people who are going to use the microscope for the first time, or even the loops for the first time, please do scaling. One of the best procedures in dentistry, non-invasive, and one of the advantages is that with the help of the mirror, you're going to see all the surfaces of the tooth. Yeah, so that if you start doing scalings on a regular basis with the help of loops, you will become more proficient faster compared to somebody who is not doing that. Are you suggesting doing scaling? You might wonder. Yes, definitely. Scaling is something which is very easy to perform. And whenever you are having free time, do something on an extracted teeth. That is how I used to do. I finished all my preclinical work under the microscope. So it really helps us to work on these things. Skill acquisition. Assistance learning curve. Obviously, there are a lot of videos online. You can watch them. You can have. You can also teach them. They need to understand, because if you do not have an assistoscope, they don't know what you are seeing. So you have to change the workplace with a lot of cameras, a lot of video, a lot of televisions, some things like that, so that the assistant can also see what you're doing. Yeah. And one of the disadvantages is that initially there are longer sessions. Doctor, I finish root canal in 45 minutes. Definitely not possible with the help of a microscope. It will take longer sessions in the initial times. I do a filling within 10 minutes. No, definitely not possible. So these are certain disadvantages, but trust me, it really works. Say 10 years back, if I had, say you consider that you want to buy a car or a microscope, given a choice for me, I would definitely buy a microscope. Why? Because the car, there will be a depreciation of the value over a period of time. But with the help of the microscope, my practice appreciates. Yeah. So it is what that is important for me. I bought the car after 3 years after I bought the microscope. But in the first 3 years, I finished off all my loans. That was the appreciation that I got with the help of the microscope. Okay, I'm talking about my personal experience. Trust me, it is worth investing on a microscope rather than on a car. Okay. Now this is the time limit and the magnification. Initially with the small magnification, say you're doing A is a scaling, you become proficient. Then you start doing something, you start doing a restoration. Again, your skills come down, again you take time. So the time taken is more initially for different procedures, and as you increase the magnification, yes, the process changes. Okay. Now this is the surgeon's position, chair position. You can sit anywhere between 10 to 12:30 if you are a right-handed person, and between 2 to 11 if you are a left-handed person. More often, the working position is between 11 to 12:30. This is more common. And the patient's neck, you can tilt it by about 45 degrees. Okay, but you need to extend it by about plus or minus 1 degree. And this is an ergonomical stool which is required when you're working under the microscope. Okay, so that your arms are very well balanced, sitting straight. Your shoulders are relaxed. You can see the first two pictures there, and if you see the last picture from the top, I'm very well balanced. I'm sitting straight. So Your musculoskeletal problems are way reduced when you work with the microscopes. Now, the golden rules to get started: talk to the dentists who have been using, take their experience. What are the problems? You need to ask what were the problems that they faced initially, how you can overcome them. Okay, attend lots of hands-on training, choose relatively easy cases, and then you take longer appointment at the beginning. Don't worry, you tell the patient, I am going to take 2 hours, and start with the lowest practical magnification. Do not jump to higher magnifications initially, but over a period of time, yes, definitely you can go with a higher magnification. Keep one hand in the operating field at all times. Never remove the eyes from the field. Okay, these were all the golden rules which I followed in the beginning. Now I would like to add one more: is watch a lot of videos, read on the internet. These videos are available freely today. Way back in 2005, no, it was not. I had to visit Dr. P.D. Joshi in 2005 end, and then he would remember. I used to stand there, observe what he was doing, and I learned from them. He taught. He is a great support for me from 2005. Yeah, but today you have a lot of videos. You can read the internet. So that is what I can suggest you how to get started with. Okay. Now, one small point, which is a clinical tip: you need to know about the mouth mirrors that you're going to use when you're using magnification, and in general also. We all of us most commonly use a rear surface mirror. Yeah. But I would always suggest you to shift to a front surface mirror, because if you see the picture, you see certain secondary images which are called as the ghost images. Okay. Now, what is front surface? When you touch the mirror, there should be no gap between the image and the probe head. That difference is the thickness of the mirror what you get. You have to be careful about that, because once the mirror gets damaged because of our boiling in water or sterilization, the quality of the reflection reduces, and that causes a lot of strain on the eyes. Now, I use one of the best mirrors that I have seen till today. They are called as the Zerk mirrors, and these are plastic coated mirrors. It's a resin, not a regular plastic, but you can see the image on the right hand side, crystal HD. It gives about 70% more reflection, I think 40% more reflection. It has 75 layers of coating. That's what I understood. I don't know how is it possible, but the images that you see under these mirrors are fantastic. You'll see it in my videos now. And this is a standard mirror with rhodium coating. Zirc mirrors are very good. It is available in India. You can look for the dealer. I think Mr. Biraj is one of the dealers, but it is, trust me, it is worth to invest on these mirrors. Okay. Now, what can a microscope do for us? A lot of things it can do. It can increase the diagnostic power. It can help us in giving a broader therapy of treatment spectrum, reduce trauma to the tissues, as I said, and marketing benefits for surgeons' professional practice. I'm using a microscope. Say there are 10 people around. Now, today, India, we have dental clinics everywhere. Say if you start using any kind of a magnification or a microscope, you can obviously tell the patients, I am one of the persons who is using this in this area. So I am doing quality practice. Do not put down the others. That's unprofessional. Put yourself above what you are doing. You become more professional there. Now, guidance to buy a loop. This is one that I just added at the end. Better visual accuracy is required. The optical quality. It is going to for better ergonomics to help improve the posture. So you need to look into what is the working distance. The cost is a factor. I know it is a cost is a factor, but it is for your requirement. You buying a microscope or buying a loop is not for the patient's requirement. He is fine with a root canal done without a microscope or with a microscope. But what are the implications of you using a microscope is very important. There are a lot of brands, and you need to know the importance of quality. it is as simple as when you try to buy a car. You go around the market, find which one is suitable, then you buy. In a similar way, you have the choices here. There should be options to upgrade with new accessories. So that is what you need to keep in mind. And the maintenance should be either free or it should be of a low cost. This is what is my line. Okay. Now, as I said, you can treat only what you can see, and you can see more and treat more. I am going to tell a few cases why magnification in dentistry is required. How once you see these videos which I'm going to show you, you'll know how microscope has defined the quality practice of mine. You can use it in periodontal surgeries. I will show one case where I have used for laser exposure. You can use it in oral surgeries, orthognathic surgeries, fixed prosthodontics. Yes, sometimes I do crown preparations under the microscope. And then laboratory, I work with a lab which also uses a microscope to check the fit of the crowns. If I am doing a crown preparation under the microscope, obviously you need to look at the labs which work with quality. They also have to use magnification. So magnification is required for delivery of quality practice for our patients. This is the bottom line. Now, coming to a few cases here, it will help in diagnosis. Yeah, that is one of the basic things. Diagnosis, you can see here, you can observe. This is one of the very old videos. Okay, I am showing you all kinds of videos that I have done. My experiences go through the years, 15 years. I was using a stainless steel mirror back then, and see the quality of the image, because my camera was not very good at that point of time. But I knew, okay, we were supposed to use a front surface mirror. Now, I used to have a television on the top, and when I used to show this patient, dear patient, this is the caries there. Obviously, he would be very thrilled to see a big image, but in that I could show him precisely where the caries is. And when we do the treatment, it would be only limited to the extent of the caries. Yeah, so that is less invasive procedure. Okay, now let me go to the second part where the microscopes helps during the treatment planning. Now, this is a case which had come to me. You can see the patient complains of pain in the lower anterior region, and you see a labial view, a lingual view. Everything looks fine. When we took the radiograph, there is a periapical lesion in relation to the tooth. That is the 3-1. Now, there was a sinus tract. If you see the radiograph, you assume that, okay, maybe there is a fracture. Yeah, so we are not sure. So what we did is we told the patient everything looks fine. Let me just raise a flap because there is a lot of crazed lines there, and the bone was completely denuded. And then we applied methylene blue dye in order to check the fracture lines. And the bottom, you can see there is a fracture line or a crazed line because of the methylene blue dye. And once we extracted the tooth, you can see that the tooth has fractured both buccally and lingually. That means the fracture line is passing through and through. Yeah. So the microscope, when you saw the crazed lines, it is going to tell me something. Please look at the fracture lines, how deep they are going, what is the cause, what might be the cause. Yes, definitely. Instead of trying to retreat the tooth. Yeah, if you try to retreat the tooth here, what is going to happen? It's a failure. Yeah, so you need to actually think about these things. Okay, lateral thinking. Now, I do restorations also under the microscope. Now, this is a small representation of the class 2 restoration which was done under the microscope. How it helps me in finding the gingival seat or the gingival margins. Please check. We do very minimal preparations, complete, and it's a controlled excavation. You can see the adaptation of the wedge, checking the cervical cavo-surface margins. Yeah, definite clean margins peripherally, which is of prime importance. One of the advantages of using a microscope is the brush. I take very minimal bonding agent, just whatever is required to be applied inside the canal. inside the cavity. Yeah, we do not require 2-3 drops at all. Just that the brush should be touched with the bonding agent, that much is enough. So I am saving a lot of money on the bonding agent. I'm using very limited amount of composites which are required. My adaptation is fine. There is no micro leakage. So I'm sure that my restorations are going to be perfectly fine. Can you observe the mirror here? This is the mirror that I'm using. This is a mirror image. Okay, maxillary are very easy to work with the microscope. This is a mirror image, and the mirrors are, you can see the reflective capacity of the mirrors. Yeah. Now coming to a few of the cases which I more commonly do, they are all endodontic related. This is a access cavity of a central incisor. See the quality of the image today. Yeah, I will go back, go in time where certain images are very poor, but way back in 2006-7 they were great images for me, because that is what I was able to record. See this, the access cavities would be very minimal in the tooth, which are actually when we start with an endodontic procedure. Yeah, there is no need for us to widen the cavity more than whatever is required. I'm not talking about ninja access and all here. I don't want to promote any kind of things. There are a lot of concepts. I am not supporting nor denying any of those concepts. I'm just here to tell what is magnification. See the quality of the image, and that is the pulp tissue there. Yeah, so this is the power of magnification that you are able to see. The pulp tissue was already necrotic. Yeah, so there was no bleeding. So this is the patient which had a history of trauma and was complaining about pain. Okay, now this is a very interesting case which I did about 2-3 years back. It's a fusion of the lateral incisors. The patient came with a history of swelling. She had a huge swelling, and we applied the rubber dam, which is a standard of care. Whenever you're working with magnification, it is required. Once I did the axis, please see the drainage. Yeah, it is just oozing out. The patient was relieved of pain immediately, and the next day when they came, we started the preparation or the cleaning process of both the teeth. Yeah, now please understand, see here, the pulp was completely necrotic and removed in total. Yeah, you can observe. Now let me just go slightly rush through. Okay, now see the drainage. Automatically, once the access is done and the pulp is removed, the drainage started by itself. Okay, and then the adjacent tooth was also opened up, and just please, yeah, let me leave it here. Just see the confluence of the two teeth. I am inserting the hypochlorite in one tooth and it is flowing from the other, right? So when you're doing that, you should know how the debris are coming out. See, you can observe certain amount of debris is coming out through this opening when we are doing the irrigation. Okay, the power of irrigation is very, very important. You take the cleaning is one of the most important steps. I use say about 30 to 40 ml of irrigation per canal in the anteriors, and it would be about more than 50 in the posterior teeth. Okay, now see the confluence. Yeah, and you will observe, because of a proper cleaning, just observe how the obturation resulted. Yeah, so you can see the radiographs. Now coming up, this is the master cone selection. Yes, we tried the length. Now I use thermoplasterized obturation. See the isthmus and the confluence, everything is obturated. This is what is very, very important. Yeah, now I showed you two cases of maxillary teeth. One of the other canine, which is a mandibular canine. Yeah, I felt initially that working on maxillary teeth are more easier than the mandible. Definitely yes. And over a period of time, once you start working, then you will get a hand, eye, and the mind coordination for the lower. It takes some time because whenever you're working on the mandibular teeth, you're going to have the work done with indirect vision. There is no direct vision, which is very unlikely only in the mandibular anteriors. But when you work on the posteriors, it is more of a indirect vision. But here again, I'm using a mirror. What I would like you to see is this is the pulp tissue. Let me, I use XP shapers sometimes when we have a wide canal for the pulp extirpation. See, the pulp tissue was removed here. Yeah. Now what I will do is, let me just rush, see here. This is the pulp tissue which was removed in total. Yeah. Just observe the anatomy. Observe the bucco-lingual extension of the pulp tissue. And now see the canal there. Okay, let me zoom it for you. So the anatomy is oblong bucco-lingually. Yeah. So this is what is important. This is what you're going to see. Now coming to the extra canals, we don't call it as extra canals. They're already present because we are already taught that there will be 3 canals. If you find the 4th, it's an extra. 5th is an extra. But honestly speaking, the pulp canal anatomy is weird. We cannot tell anything as extra. It is a normal part of the pulp canal system, yeah, or the root canal system. This is a mandibular molar. It had that is what you can see is the mid-mesial canal. We have a lot of cases about mid-mesials. I would not like to go into the details. I think there is one more video. This is a radix entomolaris. What is a radix entomolaris? An extra-distolingual root which is severely curved most of the times. See the power of irrigation, the hypochlorite which is moving there. Yeah. Now what happens is, just observe the cleaning efficacy. The canals, the floor, everything is clean, right? What you're able to see is clean canals. Sometimes this is what is not visualized when you're working without a magnification. Now this is the result. The left side is a pre-op and the post-op you can see on the right side of that patient. Now this is again a mid-mesial. Why I am showing is, please observe the mirror. It's an old mirror. The video quality was not as good as what we have now. In spite of having me done a complete cleaning there, just observe, you can still find some remnants when the magnification is increased, which tells me you still need to do more irrigation. Yeah. So just imagine, without you seeing that, how much of pulp tissue might left out in the canal before you obturate. Yeah. So you need to really think about all these 2 things. Now coming to the, just give me a second, please. Dr. Abhishek, how much more time do we have? Another 10 minutes?
Sir, please carry on. No problem from our side.
Okay, thank
can
you.
continue. No problem.
I have another about 7-8 cases to be shown. That's all. Okay. Now, yeah, this is a very important topic. MB2 location. You can. This is a pictorial representation of the chamber of a maxillary first molar. Where do you find the MB2 canals? This is something we need to look at. It has been suggested in the literature that about 70% of the cases have an MB2 canal. Yeah. So if you leave one MB2 canal untreated, what would be the success rate? It is 0, because the success rate is not like how I obturated MB, MB1, DB, or the palatal, but it depends on what I have missed. Because as I said in the beginning, if you miss something, you don't know, you're not going to treat it at all. Yeah. So you need to look for these MB2 canals. So how do you look for? When you draw a line from the MB to the palatal, okay, there's a line, and you draw a perpendicular line from the distobuccal or a tangent. In that area, when you draw a line or a circle which is having about 2 millimeter in diameter, the red dot what you see is the area where you can find the MB2. It is within that circle, the opening will be within that circle, and you might have to extend your axis a little more mesially. Okay, that is where you'll find the MB2. Now you can observe the same one. I have slightly extended my axis to the mesial side, and you will be able to find the MB2 canal. Yeah. So if you miss that, it's a problem. There is going to be a failure. So my request is always try to find this MB2 canal whenever you're doing a maxillary first molar. Yeah. Okay. Having said that, I am going to just show you one image. This is again MB2, but let me skip that. This is finding an MB2 in a maxillary second molar. So about 30% of the cases have an MB2 in the second molar also. In a similar way, we have some distobuccal too. That means second distobuccal canal. So these are the canals which are already present. These are not extra canals. This is just that we are missing to locate these canals. Okay. Now I have one picture here. Please, in your comment section, I will not mention which tooth it is right now. I would request if you can identify which is this tooth, which molar is this tooth on the left hand side on the screen, and the right side image, which tooth it is. Okay, so you can write 2, 6, 1, 4, something like that. Please put these comments. Let me see how many of you will be able to identify at the end, whether it's a maxillary or a mandibular and other things. So this here, what you see is one extra canal. You can see the dentinal map, which is very clear. And this tooth had normally has one wide canal, but here we had two separate canals. Okay. Now how many more? Okay. Now this is a root canal endodontic treatment of molar, which was done in a single visit during the pandemic session. So I will not go slow. Let me rush through. I don't want to take much time because this presentation will be there. See, the pulp stone should be removed with the help of ultrasonics. You can use your regular scalers in your clinics with a sharp tip if you feel that there is a stone. Do not use a burr. Please be careful. You have to be very careful when you're removing these stones. You should never damage the floor. Okay. Now it can be used during the shaping also. Now see, the cleaning is completed with the help of hypochlorite and 17% EDTA, which I regularly use, and activation of the hypochlorite is already done. Now what I would like you to see here is, can you observe this caries here? This is a caries which probably is still there underneath the restoration, or it is a new caries which is started in. We have to be very careful when we are working on these teeth. So that is why I paused. Now let me just go through here. Now if we observe here, this is the caries which was there when we saw through the access cavity. Sometimes we miss it. Why I was able to identify is because of the light from the microscope, the magnification and other things. So we have to replace this restoration. Yeah. So please observe that, and the master cone was selected, and then the obturation was completed. If you see, this is the previous image prior to the removal of the caries and the core buildup, while this is post core buildup. Yeah, the caries which was there was removed and the core buildup was done properly. Now apexification using MTA. This is one of my favorites. which I have been doing over a period of years. Okay, MTA. Now the concepts have changed. Regeneration is also there, like how Dr. Sai gave a lecture previously. But in certain cases, I still use MTA as for apexification. This video was done in 2007 with an integrated camera, and it is one of the first videos. It's very close to my heart. When I saw the apex, can you see that shining part is the apex? I was thrilled. Wow, I'm able to see. And then we placed MTA, we did the obturation, everything. Okay, now let me just run. I used Optura for doing the obturation. What I would like you to observe is, see, the recording was happening in a tilted part. The image was like this, right? But today we can tilt the images. Previously we did not have that facility. Yeah, today with technology we can. Now there were a lot of difficulties in recording this. I used to use a cable converter to take the image from the integrated camera, which is not convenient, convert it into an MPEG image file. So many things that we had to do. Today life has become very easy. Now this is the image of the apex today. See the clarity with which we are able to see. I just pulled this image because I wanted to show you the quality of the recording systems that we have today. Okay, now this is one more image. If you see on the top right, the red dot is the apex, which was the granulation tissue. It was controlled with the help of good amount of calcium hydroxide dressings and other things, placement of the MTA, and we get good control in the placement of the MTA. This is what was done. This is a 3-year follow-up, 2017. Now, if you can see after 2 years, probably you can see a good amount of healing. The left side, we'll have to do it, retreat that. And coming to the power of irrigation, you will be able to observe the activation of sodium hypochlorite. I use a XP shaper here, finishing file. Nowadays we are using an LED light. This image is taken still with a tungsten halide, so you can see a orange hue, but nowadays with the LED light you get a white light. Okay, so that also has added to better quality images. Okay, see the amount of activation when the hypochlorite is poured inside the chamber. Now the confluence of two canals, why I am showing this is, I know deeper in the apical part, if there is any debris which is blocking the movement of the hypochlorite, then my cleaning is not completed. But here, because of the confluence, when I insert the hypochlorite in one canal, it is coming out through the other. That means the entire canal is clean for me. So that is what I'm trying to achieve. Cleaning is the most important step. Placement of calcium hydroxide without pressure. So do not apply pressure. So it comes out through the other end because the canals are confluent. Now, perforation repair, because sometimes what happens, there are perforations which happen when we inadvertently try to remove more amount of tooth structure, thinking that it is a pulp stone or something. One of the cases, that is what had happened. We tried to remove the stone, and there was a perforation which was created on the floor. This is a maxillary tooth, so this requires a repair. My suggestion is, when there is a perforation, it has to be repaired as early as possible. Like if it happens today, if it is possible, you finish it off. Else, at least by tomorrow or whenever it is, as early as possible, try to control the bleeding, because once the granulation tissue becomes more, there's severe bleeding which happens. So you need to control the bleeding. So many things, the factors, the prognosis decreases as the time progresses. So you have to repair the perforation as early as possible. Now this is the perforation which was repaired. you can observe that all the other canals, there is no MTA which has gone inside the canals because they were blocked with the help of the paper points. Okay, nowadays we can even pack Teflon into the orifice to prevent the seepage of the MTA. As I said, I used to use what do you call the magnification when I used to use lasers. Yeah, this is one case where I used to use laser to expose a canine for my orthodontist. Okay, just see, lasers are actually less invasive, but when you use a microscope, it is still more less invasive. Yeah, so this is what I'm just rushing through, so that this was about 2 minutes video. It was done bilaterally. Okay, so both the places we were able to expose the teeth. Okay, so microscopes can be used across the board. It is not only in endodontics, so it is used in all fields of dentistry. This is just another case which was done during the pandemic. My first case after 6 months. I did not post it on the social media, but I'm posting it now. We had to take care of 2-3 things when we started practicing for the first time. I did not do the scaling. So I'm telling you that please do not feel how come there is a lot of calculus. We were really scared to use a scaler. And then what happened, we applied the rubber dam, everything. There was a gingival polyp. We used the laser to remove. And then the entire procedure was done in only one visit. So the first case during the pandemic, we were all scared. That's what I feel. We did take a lot of precautions, but yes, some small things we did miss. Now this is how we remove the pulp stone. I use the scaler, and if you can observe, never work dry inside the tooth. There should be always hypochlorite or some kind of a lubricant, anything. Most commonly I use hypochlorite inside the chamber. You can see it will be flooded with hypochlorite, and during the process I tried to remove all the calculus with the help of the probe, whatever I was able to. The cleaning was done with the help of a shaper. Okay, the master cone was taken, bioceramic sealer was used, and then obturation was completed, and the core buildup was also completed, so that we don't want to see the patient during this pandemic. My thing was to finish the entire procedure in one visit. Usually I do not practice single visit, but due to the pandemic conditions, yes. Here you can observe there is a slight split in the apical third, which was evident only after the radiograph was taken. Now this is one of the first instruments that I retrieved in 2007. Separated instrument is something that we always do. Okay, I will rush through again. I use ultrasonics. Can you see the head of the instrument? First time I saw the head of the instrument, I was thrilled. Wow, we can see the head of the instrument in the microscope. It is something which I'll never forget. So that is why I'm posting this video even today also. Now let me rush. Now can you see that the instrument is loose there, and then during the irrigation it just popped out. I did not know I could, but it had come out and I could collect it, and I collected that instrument. I still have this instrument with me. This was the level of the instrument, and you can see it was a F1 file. Now this is a case of radix centromolaris where 3 instruments were broken. I managed to remove 2, but I left the other one there itself. So likewise, a lot of cases which we have done. This is one of the recent ones which I have posted on the Facebook also. Why I'm posting it again here is to show the quality of the image. Yeah, Just see, now I'm packing Teflon to block the canals. Now the instrument is retrieved from the distobuccal canal. And this looks nice. Actually, it is always advisable to work in a wet field. To record this last part, I had kept it dry. See, the instrument is just going to pop out when it is free. These things cannot be done without magnification. Okay, that is what I would like to emphasize. Magnification is required in some point of time. Now, this is the last case, a case of apical surgery. You can see obturation done, but we planned for a surgery. This is post-obturation. Now, this is the surgery. I could not cut short this. It is about 4 minutes. So I will not run the entire 4 minutes. I will rush through. Now you can see the blood. Now, after some time, I change the filter. Okay. So it gives us a bloodless field to observe. Okay. Now this is the area in the periapical part. Okay. You can see very clearly. And then, yeah, I have applied the filter here. That is why you're able to see slightly better. Now, let us rush slightly. Now, this is the part where you do the apicectomy. The last 3 millimeters of the tooth structure is section, so that we are going to expose the apical third of the remaining GP, and then we do a retro preparation using special ultrasonic tips which are angulated according to the anatomy. Okay, now I will show you that. Now once we cut and remove that, now see the image. Now you can feel the image, but this is a micro mirror. Yeah, this is the GP which is seen. Now then we do a retro prep with the help of the ultrasonic tips. I have already done that, so I have pushed it further, and then we place MTA. Okay, mineral trioxide aggregate. This is the retro prep cavity, and then we place MTA. Okay. Now the post-op radiograph was already shown to you. Now I would just conclude all my cases. Attaining excellence in dentistry, it's the rider and it's not the bike. When we open an otherwise blinded eyes with an open and otherwise closed mind, what I would like to tell is, now that you have seen these cases, your mind was closed. With the help of magnification, I want you to open up your mind, your eyes, work more, so that there is success which is achieved. Okay, and whatever instruments that you buy, if you do not have the passion to use them, there is no point. That is why I said it is not the bike, but it's the rider which matters to win the race. Now you can contact me on all these things. I will leave the slide open. Dr. Abhishek, are you able to hear me? Okay, I think we have to.
Thanks a lot, sir. It was a beautiful presentation.
Dr. Anand, do you want me to stop sharing or something?
Yes, sir. Please stop sharing your screen, sir.
Oh, okay, just give me a second.
Yes, sir.
Is it fine? Is this what I was supposed to do?
Just stop the share.
Stop screen. Yeah.
Yeah, that's it.
Well, thank you. I'm sorry. I was searching
No
the
issues,
button.
sir.
Thank
Abhishek.
you so much, sir. It was a wonderful lecture and a perfect closure for our Endo Masterclass. You have
Thank you
covered
very much.
everything, every topic minutely and in detail. Like people are asking how to search MV2, how to do it, what to do, how to see the perforation. Everything is perfectly covered. Thank you so much.
See, I tried my level best because the time limit that you gave, I think I have exceeded. What is the time now? It's about
One
one and a
hour
half.
40 minutes. One
Oh
hour
140
my.
40
minutes,
minutes.
sir.
To all the attendees, my apologies if I have exceeded your expected time limits, because there are a lot of things that I had to cover instead of skipping things to make things clear for you. I know that I have still skipped a lot of things because I cannot cover everything in magnification in one session, to be honest with you. Whatever doubts that you people have, I will be available. You can send a comment, or you can share whatever is the post that you would like to.
You can even follow Sir's page. The name is VH Magnification. We will be posting the link in the comment section later on after this webinar. You can follow him on his page if anybody wants to
Abhishek,
know.
if we are lucky, we can have sir for one more session later for magnification or something else. Let's not leave him so soon.
Catch him. We will catch him.
Thank you very
So,
much.
sir,
Thank you.
a few questions for you, if you have some time.
Yeah, definitely. The last slide of mine was a question. So I am open for any of the questions which are there. I would try my level best to address these questions. Let me be very honest. If I do not, I will come back to you. I will get back to the answers. Okay.
Great, sir.
I remember when first time I used the microscope, I was poking the patient's nose.
Happens. I guess it
Happens.
happens with everyone.
Definitely. So that's why I told don't do anything, just do scaling.
Yes.
So, sir, the first question that I have from is from Dr. Mohammed Adil.
Okay.
A very obvious question, I guess, for someone who's trying to buy loops. What is the difference between a loop worth 4,000 rupees and a loop worth 40,000 rupees?
It's a very difficult question. On a lighter note, okay, please don't take me wrong. If you go to any of the stationery shop, you will get those lenses. You know, you remember?
Yeah.
I started to use the lens with the mirror sometimes if I'm not able to see. This is how I started, honestly speaking. And we used to use the same magnifying glass to see our old X-ray films to magnify and see. Okay, so that was about 100 rupees. I could use that also, but Dr. Adil, right?
Yes.
My suggestion is, as I said during the presentation, what is the value of your eyes? That is what I would like to know. If it's a 4,000 rupees, obviously, I'm not going to talk anything about what company, what is the quality. What am I going to see is very important. How much of eye strain that is going to cause me is what is very important. Say it's very simple. When we go to buy the prescription glasses, and the optometrist tells, okay, this is eyes, this has so many 10 coatings, 20 coatings, I want that, this. We tell, okay, let us buy that. Now, after wearing this, if I buy a 4,000 rupees worth of loop, what is going to happen to my eyes? This is
Yes,
my
noted.
question back to you. I'm sorry, I'm not trying to tell that the 4,000 is worth or not. Obviously, as I said, cost is a very important factor. We need to take a decision. It's a self decision. I'm not going to tell you, okay, you buy a 4,000 or you buy a 40,000 only. You need to weigh the options as I have mentioned today. What would be best when you have to create a balance between what you want and what you don't want? You can ask for that guy to give you the 4,000, work on that for a week's time. If you're comfortable, perfect. Not comfortable,
I like it.
call the next person. Simple. But don't
Fair
trouble
enough.
your don't trouble your eyes. That is what my request is. Request.
One more thing I would like to add: never use a loop without a light? Light is
Definitely
mandatory.
not. Definitely
Loops
not.
without lights are useless.
Yes. And as I mentioned, you need to use a front surface mirror, a good front surface mirror. And if there are any scratches, please discard it, because the image what you will get is also distorted. So you have to be really careful about those things.
Abhishek, can I take a few more questions?
Yes, yes, please carry on.
Yes, yes, please.
So one
No
more
worries.
question on loops. So I'll take a few questions on loops. So one
Yeah, yeah, yeah.
question from Dr. Nilesh Gai. How to get accustomed to loops? I've been using a 3.5x magnification loops and I don't feel comfortable working with the loops. Dr.
Okay.
Nilesh Gai.
Dr. Nilesh, yes.
Yes, yes.
Thank you very much for the question, Dr. Nilesh. Um, Definitely, what I would like you to do is go back. Don't start working on the patients if you're not accustomed to. Go back to your basics. Now, there are a few steps of how to use a loops. First is you need to check your IPD, get the loops adjusted to your IPD. Probably one of these steps are missing. You need to look at the working distance. As I said, the working distance, the field of view, everything matters. Say you have a 3.5x loop, and if you're using a 300 or a 12-inch working distance, that means the image, what you're working, the tooth, should be within that 11 to 12 inches. It cannot be at 14 inches. You will not be able to visualize at all. So you need to know what is your working distance. Once you know the working distance, say it is about 16 inches from me. Okay, I'm just showing you on the picture. So take a scale, measure 16 inches. So in this 16 inches, 15.5 to 16.5, your image should be perfect. I'm just giving you a rough measurement. You can start working on that. Then you can start to analyze, work slowly. Hand-eye coordination is something that you will get over a period of time. It is not that I wear it and tomorrow, as Abhishek told, he was touching the nose. Yeah, the mouth is somewhere else, the nose is somewhere else. So you need to get hand and eye mind coordination. I would request you to look back into these factors, go back, start working on extracted teeth so that you're able to move your hand. Try to analyze what you're seeing first, because the magnification is fixed. So you need to analyze what you're seeing and then slowly move on to the patients. There is a small learning curve. Everybody goes through that. It is like how you use your high speed in year 2. I'm not able to see anything in the maxillary with the mirror. We'll be going here and there. It is as simple as that. Okay.
Fair enough, sir. Thank you,
You
sir.
may, you may write to me if you find difficulties. I will be very happy to help you in that regard.
Abhishek?
Yes. Uh, Next question from Saroj.
What power magnification loop minimum is required for endodontic purpose, especially to retrieve a fractured instrument? Dr. Saroj Thakur, my experience is it is very difficult for us to use a loop to retrieve an instrument which is there beyond the middle third. If an instrument is there in the coronal third, yeah, it is something like you can use a 3.5 to 4.5. But obviously with the help of a light, which is a powerful light, as Dr. Abhishek and Dr. Anand told, it should be a headlight, and the depth of penetration should be very good. I would not recommend to use a loop if the instrument is beyond the coronal third or beyond the curvature, anything. It is not possible for you to get a depth of visualization in that magnification. So I would not recommend. But if it is in the coronal third, definitely 3.5 to 4.5 is good.
Thanks a lot, sir. So I have one question from Dr. Priyesha Rathod. What will be the chair position and operator position for mandibular molars with the microscope? And where should we place our mirror? Distally, buccally, or lingually? The question is on the screen, sir.
Yeah. Dr. Priyesha, what will be the chair position? The chair position, I think you're sitting in a perfect position. 12 o'clock position is a very good position. What I see from your profile picture. Um, as you see, I mentioned in one of the slides, the operator position is anywhere between 11:30 to 12:30. I hope you get the timings properly. Between 11:30 to 12:30, depending on which tooth you're working. And also, can you please run the question? The mirror position. Sorry, the mirror position. Obviously, since we are always working on indirect vision for the mandibular teeth, sometimes what we need to do is extend the mandible, and you can keep the mirror distally. Okay. Now, if you are sitting in a 11 o'clock position, obviously there will be an angulation. The angulation of the mirror will be parallel, because the image has to hit and the light has to go back to the head of the microscope. So how would I like to explain? We should get a parallel beam. Yeah. So that is how you are going to place your mirror. I'm asking, say you want to see only the mesiobuccal canal, the placement would be different. But if you want to see the distal canal, obviously the placement would be slightly different. So you will have to maneuver your mirror from the distal aspect either to the buccal or lingual, based on your position, whether you're sitting at the 11:30 or 12:30 position.
People want to know the answer of the question. People want to know the answer of the question which you asked. You posted two images.
Okay. Has anybody?
A lot of answers.
Yeah, if you could just tell me a few answers, I would be very
Somebody
happy.
answered canine, Dr. Kiran Kumar. Dr. Dhanlakshmi, first maxillary molar and second mandibular canine. Dr. Debran Mukherjee, 1-6 and 2-4. Dr.
Okay.
Shruti Handa, left first maxillary molar and right canine maxillary.
Okay, it's a maxillary canine which had two canals. Some of you have got it correct. And the molar was maxillary 1-8,
Wow.
which had two palatal canals.
The image was amazing, sir.
Yeah, that was a very, usually I'm not a person who does root canals for 8 unless otherwise it is required for prosthodontic purposes. This tooth was a very good tooth because the patient had lost 1-7 at a very early age. 1-8 was the last ponding. And then when I started to remove and I saw the dentinal map, it was taking me more distally. I told, no, it's okay, you go today, let me check back again, because I didn't expect that there would be another canal. And then tomorrow when I started removing with the help of the ultrasonics, I was like, wow, you have one more root. It's not a canal. I was like, thank God I was using some kind of a magnification which I was able to help the patient there.
Was the patient a human being or a crocodile? That amazing image in an upper 8.
Definitely, he was a wonderful patient for me, very cooperative. And for one of the most luckiest thing is he had a very good mouth opening.
Exactly.
Doing 1-8 with two palatal roots was something, and to get that image,
Exactly.
was very perfect.
That image didn't make us think that it would be an 8.
Definitely not. Definitely not.
Last thing, one question from Dr. Swapnil. Sir, please give the message for the beginners. This is the last question for tonight.
I guess that's a perfect end.
Yeah.
On Teachers Day, from a good teacher, we need some message. Strong message for all the beginners.
2020, COVID-19 has been the best teacher, and it taught us something very good. Be patient. You have all the time in your life if we survive. Yeah. In a similar way, you have all the time in dentistry. Go slow, stepwise, and take small steps. You cannot jump. This is what is something that I would tell everyone. Take small steps. Discuss with your friends, colleagues, your teachers, whoever is using a microscope or any magnification, learn from their mistakes. That is what is very important, because we don't want you to do the same mistakes, and buy something which is worthwhile. Now you balance yourself. Do I need a new Hyundai Accent car or whatever is available presently, or would I invest on a microscope for my practice to improve? These are the decisions that you need to really make, so that it is going to take you to the next level compared to your contemporaries who are still thinking about that. So the first step that you take is very important. It's a very hard step. 2008, when I bought the microscope, that was a recession period, and people were like, "Are you buying a microscope during a recession?" I told, "I need to get out of this recession quickly." Yeah, and I did that. I finished all my loans in the first 3 years. I break even. Please understand, you can just increase the pricing by about 500 rupees. Do not increase it by thousands. 500 rupees for a procedure. Slowly, you take stepwise, because initially you're learning on a patient. So don't don't take all the money from that single patient there. Yeah. So like this.
Thank you so much, sir, for the wonderful session once again. And
I
yes,
have
please.
just give me one. I have one or two slides which are left out, because I need to give my acknowledgements to the people who have helped in this presentation. Can I share my screen if you do not mind?
Yes, please,
Sure,
please,
sir.
please.
Yeah, please.
In the meantime, special thanks to Dr. Abid from our side for helping us in setting up this webinar.
Okay, here this is one of the slides that I always like to tell. Life isn't about finding yourself. Life is about creating yourself. Okay, and thank you, the team of World Dental Association, and all the attendees who have been there, helping me and giving me an opportunity to share my experiences. And these are the acknowledgements, Dr. Glenn, and certain books from Dr. Enric and Stephen, and Marco for some of the images that I have taken. Okay. Now the questions, as I said, this is the image. If anybody wants to catch up with me, these are the contact details. At any point of time, you can drop in a message or anything. Okay. Thank you. Thank you. Stop sharing. Yes. Thank you, Abhishek. Thank you very much for
Thank you,
this
sir.
wonderful opportunity. Dr. Anand, thank you very much. And
Thank you, sir.
at the end, I would like to thank all my teachers on all your behalf, for all the people who have been guiding one and all in this dental fraternity. Thank you very much.
Thanks a lot, sir.
We also thank all the teachers who have conducted the Endo Master class rigorously for all of us. They have given us whatever they have learned through all the experiences in their lifetime. Thank you, all of you, from the bottom of my heart, from all of us in WDA team. Thank you, everybody. Next week, we will be starting with the Rubber Dam Masterclass and followed by Perio Masterclass. Stay tuned. Thank you, everybody.
Abhishek,
Anand.
yeah,
Yes.
I just would like to end the Endo Masterclass. I just want to make a small announcement, if you please allow me. And Vinay, sir, please.
By all
So
means,
I guess
it
so.
is
It
yours.
was around. Thank you, sir. So it was around 4 months back that me and Abhishek were having a phone call, and Abhishek came up with the idea. So this was Abhishek's brainchild. That let's have an entire series of endodontics, because endodontics is the bread and butter of dentistry, especially in India, if not anywhere else. So he was very serious about it, that we have to go through the entire series from right from the beginning till the end. We don't want to leave anything away. That's how we came up and we planned this entire series. And we had 21 sessions. And I was just checking right now during the discussion, sir. It has been 78 days since we started the Endo Master class, and I haven't
Fantastic.
realized that it has been going on for such a long time. It was an amazing series which started right on the 19th of June with Dr. Mahmood Hamo, who spoke about diagnosis. We moved on to Dr. Ajay Bujaj, who spoke on anesthesia, Dr. Niranjan Bhatka, who spoke on rubber dam isolation, which I guess is the most important right now, Dr. Shail Jaggi ma'am, who spoke on access cavity preparation, Dr. Ashish Jain sir, who spoke a lot about working length and apex locators. So your guru, Dr. P.D. Joshi sir, was with us, and he spoke on one of the biggest topics, cleaning and shaping, right from, glide path to gauging. Then we had Mandar Pimprikar sir, the boss of irrigation from India. We had Devrat Singh sir. He was again from Dubai, from somewhere close to you. He spoke at length about sealers. We had another guru, Dr. Vivek Hegde sir, who spoke about obturation. Professor Raghu Narayan from Bangalore, who spoke on post-10 course. We had a lot of speakers from Bangalore. We had
Okay.
Dr. Shivi Sridhar, who spoke about restorative dentistry after endodontics, so restorodontics. We had Dr. Zahir Al-Taki, again from Saudi Arabia. He spoke
Yeah.
about MTA and perforation management. We had Dr. Ruchita Ruptal Nawal madam. She spoke about resorption. We had Pradeep Shetty sir from Pune. He spoke about fractures. We had Dr. Siju Jacob, again from Bangalore, but he was in Dubai during the session. He
Yeah.
spoke about periapical lesions. We had Viresh Chopra sir from your city, from your country.
My
He spoke
country.
about retreatments. Then we had Harsh Amlani from Baroda, who spoke about instrument retrievals. Then we had Dr. Sai Kalyan, your dear friend, who spoke at length about tissue engineering and revascularization. Dr. Pavna Kamath, who spoke about single visit endodontics. Then we had Dr. Anish Navre, who spoke about different cases, wide variety of cases in endodontics. And finally, today, you, Dr. Vinay sir, who spoke beautifully about magnification. I guess it has been a super exhaustive series. I can't think of any topic in endodontics which is left to be covered. So, Endo Masterclass Season 2 is going to be something different and something unique. Let's see what we come up with. Thanks a lot to all the teachers. It is, I guess, the best time to thank everyone on Teachers' Day. And as Abhishek just mentioned, with COVID, rubber dam becomes the next most important thing. So we are coming up with a rubber dam masterclass for 3 sessions. And then we have a perio masterclass coming up. So stay tuned. And yeah, obviously, this is not the end. I have been getting messages. I'm sure Abhishek also has been. We will be following it up with prostho masterclass and implant masterclasses as well. We are not stopping. Corona is not going anywhere. So are we. We are here to stay.
Once again, congratulations on your efforts, both of you and your entire team. From all of us who have been a part of your team and you giving us an opportunity, I take the liberty taking, because I know most of them, and I take the liberty from all their side to congratulate all of you in team WDA. Okay.
Thank you, sir.
Thank you very much. Thank you.
Thank you so much,
It's a
sir.
team effort. Thank you, sir.
Thank you, everybody. Good night. See you all very soon. Bye-bye.
Bye-bye.
Thank you.